A great day again to everyone. So, today we are going to discuss non narcotic and narcotic analgesics. So, we'll talk about pain because these drugs are used to treat pain. So, it is mostly a subjective experience. Take note of subjective because we are not the ones feeling it, it is the patient themselves. So it's a subjective experience of unpleasant sensation and emotional experience. People respond to pain differently. So, for example, some have or can experience intense pain with just a little amount of pain, or some can experience or have a high tolerance for pain. So, let's say, for example, some people they take injections for granted, while some people may experience injections as a very painful experience. So pain is different for the patients that we have. So people respond to this differently because of cultural differences, learned experiences, and environmental stimuli. So the A delta and the C fibers are the two sensory nerves that respond to stimulation by generating nerve impulses that produce pain sensation. So these two types of nerves are the ones responsible for pain. So take note of these two. Acute versus chronic pain. So, acute pain is caused by tissue injury. This is the type of pain which makes the person aware of the injury and leads him or her to seek care and education about the injury and how to take care of it. So, this is what we usually feel. For example, if you accidentally cut yourself or accidentally burned yourself with boiling water, you will feel acute pain there. But for chronic pain, it is a constant and intermittent pain that keeps occurring long past the time the area would be expected to heal. So, this is the type of pain that can interfere with the activities of daily living. There are certain diseases like cancer that can cause chronic pain to occur. So, if your cancer is found around the gastrointestinal organs, you will feel chronic pain around that area. Or if a patient has bone cancer, where the bone cancer is growing, the patient is going to feel chronic pain from there. Now we go to pain classification according to the source. We have nociceptive pain, which is caused by direct pain or caused by direct pain from the receptor stimulus. That is nociceptive pain. So, for example, you accidentally pricked yourself with a needle, or you accidentally touched the hot surface of a pot. That is nociceptive pain. While for neuropathic pain, it's caused by nerve injury. Let's say, for example, a person was um, had a below the knee or above the knee amputation. Because there is nerve injury that has happened there, they are going to experience neuropathic pain since the nerve has been cut off. Psychogenic pain, it's associated with either emotional, psychological, or behavioral stimuli. There are certain patients who are suffering from psychiatric disorders. We call them somatoform disorders. When we talk about somatoform disorders, their psychiatric or their mental issues is converted into physiologic ones. So, a great example there would be patients who are suffering from conversion disorder. They convert psychological problems into physiologic ones. So their psychological problem becomes a physiologic pain instead. That is psychogenic pain. There are certain persons or patients who experience this kind of psychiatric disorder. Now we go to non-narcotic drugs. I'm going to skip most of this because we have already discussed this during NSAIDs. You can see Tylenol here is very, very common in the United States or North America. Here in the Philippines, paracetamol, biogesic is the common one, either biogesic or tempra. I've already mentioned to you the different types of non-narcotic drugs, with the exception of this Exparel, which is bupivacaine liposome injectable suspension. So that is injected subcutaneously. And bupivacaine, you need a prescription to buy that. Usually for non-narcotic drugs, you don't need a prescription for them. I'm going to skip most of this. We already know all about this regarding ibuprofen. We have paracetamol, acetaminophen, aspirin, mefenamic acid. What else? Naproxen, and so on. Now we go to the narcotic drugs. This is the one that we haven't discussed yet. Narcotic drugs are the drugs that react with different types of opioid receptors. These are receptor sites that respond naturally to occurring peptides, enkephalins, and endorphins. These are found in our CNS, the peripheral nerves, and the GI tract cells. In the spinal cord, they integrate and relate pain information. And pain relief and side effects depend on the type of receptor sites. So, what narcotic drugs do is that they bind to the opioid receptors in the CNS in order to block the transmission of pain. Because there are certain chemicals, the ones I've mentioned here, the peptides, enkephalins, and endorphins, they these can either block or transfer or transmit the information of pain. Now we go to the different types of opioid receptors and um, what what they are about. We have the mu opioid receptors. They are primarily pain blocking receptors. They account for respiratory depression, or also account for respiratory depression, euphoria, and development for physical dependence. So mu opioid receptor type of drugs, they can cause an adverse effect known as respiratory depression. That's why when we are giving narcotics, it is very, very important for us nurses to monitor the patient's respiratory rate. And take note, they can cause euphoria. That's why it is highly addictive. That when we talk about euphoria, this is the high feeling that the patient will feel when taking narcotics or opioid analgesics. That's why these drugs are controlled. These are controlled substances because they have or they are causing physical or psychological dependence. Now we also have beta receptors. They modulate pain transmission by reacting with enkephalins in the periphery. Kappa receptors, these are associated with some analgesia and can cause pupillary constriction. So it can constrict the pupils, sedation, and dysphoria. And sigma receptors, they cause pupillary dilation, which is the opposite of kappa receptors, hallucinations, psychosis with narcotic use. So if you abuse these drugs, the sigma receptors, they can cause hallucinations and psychosis. And the narcotic drugs are divided into three classes. We have the narcotic agonists. They react with opioid receptors in the CNS, cause analgesia, so they remove pain, sedation, or euphoria. You will be high when you take narcotic agonists. They are classified as controlled substances because they have high potential for physical dependence, so they are highly addictive. Narcotic agonists, antagonists, stimulate certain opioid receptors but block other such receptors. They exert similar analgesic effect with that of morphine but have less potential for abuse. However, they are associated with more psychotic-like reactions, so they can cause psychoses, these type of drugs. And lastly, the narcotic antagonists, they bind strongly to opioid receptors without causing receptor activation. And they block opioid receptor effects as well as effects of too much opioids in the system. That is why we give narcotic antagonists to patients who have an overdose to narcotic agonists because they block them. They antagonize the narcotic agonists. So we have narcotic agonists. Therapeutic action of narcotic agonists is to act as an agonist to specific opioid receptors in the brain to produce, or the brain and spinal cord, the CNS, to produce analgesia, euphoria, and sedation. That's example of those are morphine, oxycodone. What else? Meperidine hydrochloride. These are narcotic antagonists. So indications is to relieve patients from moderate to severe acute pain or even chronic pain. They can be given as pre-op medications as well, and component of combination therapy for severe chronic pain. And they can be given intraspinally to reduce intractable pain. It's an excruciating type of pain felt by patients who have or who are suffering from some CNS disorders that is causing pain. Now, if the patient is taking this, it is our responsibility to monitor the patient's respiratory rate. If the respiratory rate goes down below 12 cycles per minute, we need to report this to the physician immediately and prepare naloxone, since naloxone is the antidote for narcotic overdose and to reverse the effects of narcotics. They are also used to or used in labor, such as morphine, meperidine, and oxymorphone. All narcotic agonists are pregnancy category B, so they're slightly safe to be given to pregnant women, especially those in labor, except oxycodone, which is category C. So it might be the drug of choice if one is needed during pregnancy or during labor and delivery. Contraindications and cautions. If you have allergies, of course, diarrhea caused by toxic poisons. This drug depresses GI activity, and this could lead to increased absorption and toxicity. So if the patient is undergoing diarrhea because of toxic poisons, do not give this drug because it will somehow paralyze the GI. That's why there are certain drugs or certain antidiarrheals that contain narcotics because they can paralyze the GI tract, especially for patients who are suffering from diarrhea. They can be anti-diarrheal as well. That's why one of its side effects is it causes constipation. Respiratory dysfunction. So if they are suffering from any respiratory disease, this is contraindicated. It will exacerbate respiratory depression in patients who have a respiratory disease. Recent GI and GU surgery, or those with acute abdomen or abdominal infection, ulcerative colitis as well. This can worsen the GI depressive effects of the narcotic, or they can be worsened by the GI depressive effects of the narcotic, since they can cause GI paralysis. Head injuries, alcoholism, delirium tremens brought about by alcoholism, cerebral vascular disease, they can be exacerbated by narcotics. So do not give narcotics for those who have head injuries, alcoholism, or delirium tremens. This is where the patient is experiencing hallucinations brought about by alcohol intoxication. So do not give narcotics. Liver, renal dysfunction, do not give narcotics as well because it can interfere with the metabolism and the excretion of the drug. Pregnancy and lactation. So there are some narcotics that cannot be given during pregnancy because it has potential effects to the fetus and the baby. They can only be given during labor and delivery in order to ease the pain felt by the mother. Adverse effects, CNS, there's lightheadedness, dizziness, psychosis for some, anxiety, fear, hallucinations can occur, pupil constriction, impaired mental processes. So because if you take narcotics, you'll slightly be sedated. So if you are high, you are not by yourself. For GI, there's nausea and vomiting. There's constipation. I mentioned that earlier, and biliary spasms. So the patient might feel right upper quadrant pain because of biliary spasms. Biliary or bil the tri- biliary tree is found between the liver and the gallbladder. GU, it can cause ureteral spasm, urinary retention, hesitancy, and there may be loss of libido from narcotics. So for males, they might not be able to perform while they have or they are taking narcotics. Others, there's excessive sweating, physical and psychological dependence. Not next. It's very, very important because narcotics can cause respiratory depression and it can be coupled with apnea, cardiac arrest, or shock. So you need to watch out for the RR of the patient. Do not give narcotics with these drugs, barbiturates, phenothiazines, and MAUIs, because they will increase the likelihood of respiratory depression, hypotension, and sedation. So do not mix them. Also with SSRIs, TCAs, and St. John's wort for the increased risk of potentially life-threatening serotonin syndrome if taken with tapentadol, the newest narcotic agonist that blocks norepinephrine reuptake in the CNS. Methylnaltrexone bromide or Relistor is the treatment for opioid-induced constipation in palliative care patients who are no longer responding to traditional laxatives. So if there's opioid-induced constipation, methylnaltrexone bromide is the drug of choice to help patients, the elderly patients, to have a bowel movement if laxatives are no longer working. Now we go to narcotic agonists, antagonists. Therapeutic action is they act on certain opioid receptors but block others such receptors. So with these drugs, they have less potential for abuse compared to narcotic agonists, but they are able to exert similar effects, analgesic effects that of morphine. Indications of narcotic agonists, antagonists, again for relief of pain, moderate to severe, for pre-anesthetic medications or supplement to surgical anesthesia. They are also given to pain or to relieve pain for those patients who are experiencing chronic pain. So examples of the narcotic agonists, antagonists would be butorphanol, pentazocine, nalbuphine, buprenorphine, and eluxadolin. So these are examples of the narcotic agonists, antagonists. Nursing responsibility, again, we need to provide baseline and periodic pain assessment with patients to monitor drug effectiveness and provide appropriate changes in pain management protocol as needed. That's why it's very, very important for us to assess the patient's level of pain. So we are going to ask with the pain rating scale from 1 to 10, how much or how intense the pain that the patient is currently feeling. And have a narcotic antagonist and equipment assisted ventilation readily available when administering this drug IV to provide patient support in case of severe reactions such as respiratory depression, to have those things available. Monitor timing of analgesic doses. Prompt administration may provide a more acceptable level of analgesia and lead to a quicker resolution of pain. So you need to note the timing of the dosages as the doctors order. Provide non-pharmacological pain measures as well, like breathing exercises, back rubs, and stress reduction to increase drug effectiveness and reduce pain. So you need to do diversionary activities when in order to divert the patient from the pain, such as watching TV, reading books, listening to music, playing video games. These are the ones that I am doing sometimes. Provide comfort measures such as small frequent meals for GI upset to help patient tolerate the drug effects because they can have nausea and vomiting with it. Provide safety measures, again, adequate lighting, wayside rails in order to prevent injuries. And educate the client on drug therapy to promote understanding and compliance. So, when is the best time to take the drug, when they are, what are the side effects of it. So, we need to teach them those things. And lastly, we go to narcotic antagonists. Their therapeutic action is that these are drugs that bind strongly to opioid receptors, but they do not activate them. Instead, they block the opioid receptors and reverse the effects of opioids like respiratory depression and sedation. These are given to patients who have narcotic induced respiratory depression. So, if the respiratory rate falls below 12 cycles per minute, we need to give this to reverse its effects. Or those who are experiencing opioid overdose. For addicts who have overdosed from morphine, for example. Nursing responsibilities when giving naloxone is to maintain an patent airway or open airway. That's very, very important. And provide artificial ventilation and cardiac massage as needed to support the patient. Administer vasopressors. These are cardiovascular drugs. You will learn more about them once we're in the cardiovascular system drugs. Administer naloxone before giving naltrexone because of the serious risk of acute withdrawal. So naloxone first before naltrexone. Same safety measures will be applied to prevent injuries. And those who have been giving or receiving naltrexone, we should check if they are narcotic free for at least around 7 to 10 days to prevent withdrawal syndrome. So we need to assess that first. And again, educate the client about the side effects and when to take this drug. But most likely, probably we're the ones going to give it to them because they might be suffering from respiratory depression by then when we are going to give naloxone to our clients. Okay, next would be anticonvulsants. Now we go to the next topic, which are anticonvulsants. These drugs, they are used to treat epilepsy or other seizure disorders since they help control convulsions or seizures. That's what their name is for, anticonvulsants. Now, for epilepsy, it's a collection of different syndromes, all of which is characterized by sudden discharge of excessive electrical energy from the nerve cells within our brain. And the resultant action is or are seizures. So it will originate on one side of the brain and spread all throughout this abnormal electrical discharges inside our brain. And if you're going to ask me what causes this, the cause of seizures is still unknown. Doctors still do not know why seizures happen in epilepsy. But they can, or there are certain conditions that might trigger seizures, such as head injury. So if you have a head injury or infection, for example, this can happen. This can bring about a seizure. Nature of seizures. So this depends on the location of the cells that initiate the electrical discharge, as well as the neural pathways which were stimulated. Seizures can be primary, no underlying cause. This is the one that I was talking about. It has no cause at all. The cause is unknown. Or secondary, brought about by external factors such as head injury or an infection. So if the person has an infection of the brain, such as encephalitis or meningitis, this or seizures can happen. Or another one, if there's increased intracranial pressure brought about by hydrocephalus. If you have seen an infant who has a very large head, seizures can happen as well. Status epilepticus, this is very, very dangerous because it is a state where seizures rapidly occur or recur with no recovery between seizures. And it's the most, or it is potentially the most dangerous type of seizures because even if we give anticonvulsant drugs and the person or patient is not relieved by it, that is already status epilepticus. And sometimes they can last as long as 30 minutes. So imagine a patient suffering from seizures for 30 minutes. That is very dangerous and very exhausting for the patient. International classification of seizures. We have they categorize seizures based on symptoms and characteristics. There are two main categories. They include generalized seizures. They begin in one area of the brain and rapidly spread throughout both hemispheres of the brain. Partial seizures or focal seizures, they begin and remain in one area of the brain only. So these are the two. So generalized, begin in one area and spread all throughout the brain, both hemispheres, while partial or focal seizures are only localized in one area of the brain. Generalized seizures, they are characterized by massive electrical activity that begins in one area and spread to both hemispheres. Usually, it is accompanied by loss of consciousness. For focal, sometimes there's no loss of consciousness there. Classification of generalized seizures are the following. You have tonic-clonic or grand mal seizures. So it involves involuntary muscle contraction, tonic, which you can see here, followed by relaxation appearing as an aggressive spasm, clonic, and loss of consciousness is going to occur. Confusion and exhaustion in the early recovery period. That's why after the patient has had a seizure, we need to reorient them to where they are, what time it is, your name as the nurse, because they can have confusion. They are disoriented after a seizure. That's tonic-clonic or grand mal seizures. These are seen in patients who are suffering from epilepsy or even seen from patients who have head trauma or suffered a head trauma, who have meningitis or encephalitis. Absent seizure or perimal seizure. It is an abrupt and brief 3 to 5 second period of loss of consciousness common in children starting at age 3. As you can see here in this demonstration, that's an example of absent seizure, but disappears at puberty. And the seizure does not usually involve muscle contraction. As you can see, they have sudden bouts of staring spell. So they are going to stare at you. Their face is going to appear blank for 3 to 5 seconds. That is absence seizures. Myoclonic seizure, it's characterized by short sporadic periods of muscle contraction, as you can see from this patient. It's just short and it can last for several minutes. And it is relatively rare. Febrile seizures, it's a self-limited seizure related to very high fevers. And I am a living testament to this. I had febrile seizures when I was young. So usually the trigger for these seizures is an infection. If there is a high increase in the body temperature of the patient, febrile seizures will occur. It's usually related to high fevers. That's why it's named as febrile seizures. And my my son also inherited this from me. When he was young, he had febrile seizures before. So let's say he had an upper respiratory tract infection that causes him to have high fever. This can happen. And they commonly occur in young children, children below the age of 6 years. And they cannot grow them later on during school age. So this disappears later in life. My son, if he has fever now, since he's already 13 years old, he no longer experiences this. Of course, I do not experience them anymore. They're only found in children below 6 years of age. Not all children experience that though. Now we go to Jacksonian seizures, begin in one area of the brain and involve only one part of the body, but that this later spreads to other parts until a generalized tonic-clonic seizure has developed. So there will be jerking movements of one limb, for example, until eventually it will be a full-blown seizures. This is Jacksonian seizures. Partial focal seizures. They are characterized by seizures that originate from one area of the brain, but they do not spread to the other parts, and they can be further subdivided or classified into two. Simple partial seizure, it only occurs in a single area of the brain and may involve a single muscle movement or sensory alteration. So, a limb may jerk for a few moments. But for complex partial seizure, it is a type which occurs by late teenage years and involves a series of reactions or emotional changes and complex sensory changes such as hallucinations, mental distortion, personality changes, loss of consciousness, and loss of social inhibition. Motor changes may include urination, chewing movements, and diarrhea. So, unlike that of simple partial seizure, there will be jerking movements of some limbs. For complex partial seizures, aside from those, they might experience sensory changes and psychological changes as well. So, we have three types of drugs that are used to treat tonic-clonic seizures. We have Hydantoins, barbiturates, and barbiturate-like drugs. So, these drugs, they are used for the treatment of generalized seizures in order to exert their therapeutic effect by blocking channels in the cell membrane or by altering their cell receptor sites. As a result, nerve membranes become stabilized, and their work involves the entire nervous system, so sedation is an expected result. So when we're giving anti-convulsant medications, anti-seizure medications, we are going to apply the same teaching that we are giving to patients who are taking sedatives or sedative hypnotics, not to drive or operate heavy machinery again. So, drugs that are used to treat generalized seizures, I've mentioned them, Hydantoins, barbiturate drugs, or barbiturate-like drugs. Benzodiazepines, we've already discussed them. I've also told you before that benzodiazepines can be given as an anti-seizure medication. And succinamides. Benzodiazepines, they are primarily given when a seizure is occurring. That's why if the patient is exhibiting seizure in the hospital, they will be given IV diazepam immediately. It's stat. Succinamides are drugs that modulate the inhibitory GABA, and they are used to treat absence seizures or perimal seizures. Hydantoins, they always end in the suffix toin, 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 like phenytoin, mefenitoin, ethatoin. These are drugs that are given to patients with epilepsy. These are their maintenance drugs. So they will take them every day in order to help them control their seizures. Therapeutic action, they stabilize the CNS membranes by decreasing the excitability and hyperexcitability of ionic channels in the cell membrane to stimulation. So they inhibit those things, the excitability and hyperexcitability of the nerve cells. Since people with epilepsy have hyper excited, um, hyper excited or excited neurons in their brains. They decrease the conduction through nerve pathways and reduce tonic-clonic, muscular, and emotional responses to stimuli. So Hydantoin indications, control of tonic-clonic and psychomotor seizures, prevention of seizures during neurosurgery, and control of status epilepticus as well. So if the patient is undergoing neurosurgery, these medications can be given. These medications, they are less likely to cause sedation, which makes them the drug of choice for patients who are not willing to tolerate sedation and drowsiness brought about by benzodiazepines. And take note, these are the drug of choice for patients who have epilepsy. However, this class have severe side adverse effects that benzodiazepines have replaced them in many situations. Contraindications, of course, to those who have allergies from it, those who are pregnant and lactating, because there may be problems with the fetus or newborn if you give them to mothers who are pregnant or lactating. Debilitated patients, they may respond adversely to CNS depression if this happens. Those who have impaired hepatorenal function, so it interferes with drug metabolism and excretion. That's why the doctors, they need to test the liver and the kidney function before administering this drug. Coma, depression, and psychosis. Do not give them to those types of patients because they can worsen these conditions brought about by CNS depression. Hydantoin adverse effects. They can cause depression, confusion, drowsiness, lethargy, fatigue in the CNS. For the cardiovascular, they can cause heart arrhythmias, changes in the blood pressure as well. For the GI, they can cause constipation, dry mouth, and anorexia. For genitourinary, there's urinary retention and loss of libido as well. And cellular toxicity can happen with the Hydantoin treatment. So it's characterized by severe liver toxicity, bone marrow suppression, gingival hyperplasia, and serious dermatological reactions such as hirsutism. So excessive growth of hair for patients, or there may be Steven-Johnson syndrome. So in Steven-Johnson syndrome, SJS, it's a rare serious disorder of the skin and mucous membranes wherein they react with hydantoins differently and they develop flu-like symptoms followed by a painful rash and that spreads and blisters. Then the top layer of the affected skin dies, it sheds, and begins to heal after several days. This is the Steven-Johnson syndrome brought about by certain medications. Hydantoin interactions, if you give them with alcohol, it will increase the risk of CNS depression. So do not give them with alcohol. Evening primrose, it can increase the risk of seizures. That's why do not give evening primrose to patients who are taking hydantoins. Because evening primrose, they can be given as tea. So do not give evening primrose tea for patients taking hydantoin. Ginkgo, there are certain foods that contain this. There will be an increased risk of serious adverse effects when taken with phenytoin. So do not give foods that have ginkgo or ginkgo biloba. Now we go to succinamides. Example, those ending in succimide, ethosuximide, fensuximide, and methosuximide. So these are drugs ending with the suffix succimide. The therapeutic action, they act in inhibitory neuronal systems and suppress the electroencephalographic pattern associated with absent seizures. So it's for absent seizures. Most frequently used to treat absent seizures and reduction of frequency of attacks of these type of seizures. Contraindications and cautions, same with Hydantoins. Adverse effects, CNS, almost the same with that of Hydantoins, but there can be drowsiness, fatigue, ataxia, so it's difficult for them to move. There's insomnia as well. So it's either drowsiness or insomnia can occur. It can occur differently from certain types of people. Headache and blurred vision. For GI, there will be decreased GI activity leading to constipation, or the opposite, diarrhea. There's nausea and vomiting as well, anorexia and weight loss. Direct irritation of the skin and bone marrow. It can cause bone marrow suppression, so watch out for it. Watch out for the red blood cell, the white blood cell, and the platelet counts of the patient because it can cause fatal pancytopenia. Meaning, pancytopenia, all of the blood cells are decreased. So they will be at risk for bleeding. They will be at risk for infection since the white blood cell count is depressed, and oxygen carrying capacity of the blood is also decreased because of the decreased levels of red blood cells. Urticaria can occur, so they can have that together with alopecia and again Steven Johnson's syndrome. Ethosuximide has relatively few adverse effects than that of the other anti-seizure agents, so this would be most appropriate to patients who have absent seizures, the ethosuximide. Interactions with primodine will decrease the levels of this drug. So do not mix succinamides with primodine. Primodine is used to treat seizures as well, but do not mix them together with succinamides. Nursing responsibility: monitor the adverse effects and provide appropriate supportive care for the different adverse effects that the patient is experiencing. And when giving succinamides, it's very, very important to monitor the CBC. If the CBC levels are falling down, the RBCs, WBCs, platelets, we need to inform the physician immediately because there's bone marrow suppression. And discontinue the drug for any signs of allergic reactions or hypersensitivity reaction, liver dysfunction, and severe skin rash if there's already Stevens-Johnson syndrome. Provide comfort measures, positioning of the legs and arms if there is dyskinesia or difficulty in movement, sugarless candy and ice chips for dry mouth, avoiding before taking the drugs for urinary hesitancy or retention because they can occur in order for them to tolerate the drug effects of succinamides. Provide safety measures, same as well as the other anti-seizure drugs. And we need to educate the patient about the adverse effects and what these drugs do to the body. So that's it, everyone, for today's lecture. If you have any questions about the narcotics and anticonvulsants, please just send me a message. I'd be more than glad to help you with them. Again, thank you very much for today, and God bless you all on your upcoming exams. Have a great day, everyone. Bye.